Hi guys, welcome to some de-escalation training for UNC hospital staff. I hope you all are well today, and we're going to talk about the use of restraints and de-escalation. So a restraint is any action or procedure that prevents a person's free bodily movement to a position or normal choice of access to his or her own body, and it will prevent them from moving so that they cannot control themselves easily. Restraints can be chemical, physical, and environmental. Examples of restraints would be bed rails, lap belts, wrists, ankle restraints, and or chairs with trays, anything that's going to restrain a patient from moving freely. It's important to understand when to use a restraint, and restraints are often overused due to understaffing and lack of education or inadequate training. Um, so we want to prevent the use of restraints because it is harmful for patients physiologically and psychologically, and can also prolong their hospital stays. And it's also damaging for providers if they overuse restraints or use them in the wrong situations that can often lead them to guilt or feel like they're in an ethical dilemma. So our question this morning that we want to address is, in non-psych nurses, how can de-escalation training compared with standard training affect the prevalence of physical or chemical restraints? So I would like to now ask, do each one of you or any of you have any stories about restraint use or the prevalence of restraints on your floors or in your own experience that you would like to share?
I'll share one of mine. My patient today was experiencing delusions that I was there to harm her. She became aggressive and tried to run to the door. And this was during lunchtime, and a couple of the other nurses had taken a break, so we split up their patients to take care of while they were gone. And we were already spread pretty thin, so I didn't feel like I could go ask someone else for help and leave the patient. I needed to calm the patient down pretty quickly and move on to another patient who had their call light on and needed help. So I ended up restraining the patient to keep them in the room.
I agree that not having enough staff is a huge barrier to using de-escalation techniques instead of restraints. Research supports that adequate staffing can improve the rates of de-escalation, which is why it is listed as a clinical guideline for implementing de-escalation.
I also had a patient recently who was very upset about being involuntarily admitted to our unit, and she didn't believe that she should be here. So when I tried to provide care for her, she got very agitated and became aggressive and combative towards patients and staff. I was unsure how to properly de-escalate the situation, and I was concerned for the safety of myself, my peers, and other patients. So I got an order from the doctor to utilize a pharmacologic restraint, but I feel like with more training, I would have been able to better handle the situation, and could have avoided using any kind of restraint on the patient.
I also do not feel like I have enough training with de-escalation techniques to feel comfortable safely implementing it. There's a lot of evidence that says providing de-escalation training and improving staff knowledge about de-escalation will decrease the use of restraints and increase the use of de-escalation. Providing de-escalation training to staff is one of the most important clinical guidelines for reducing the use of restraints.
Some of the other clinical guidelines that we could see used during our clinical time is creating a safe space for clear communication between patient and staff, while also performing a risk assessment upon admission, so we can tailor the de-escalation strategies for those patients, combined with adequate staffing and adequate knowledge and training.
Great. These were all amazing examples of how we can decrease the use of restraints in our own clinical practice. Now let's move forward with our de-escalation training. Thanks, guys.